A very good morning to all of you. You are watching Urogynecology for Beginners. And today we are going to discuss one interesting case. Last time also we discussed with Dheera, a case of voiding dysfunction. Today also a little severe variety with a different cause we are going to discuss. And some people have been asking me that why we are not posting surgical videos in our channel for some time, and the fault is theirs. They are not recording it properly. So you can blame them, but I'm sure that soon you guys will edit some videos and post it.
Yes.
Because the videos are not getting recorded, so we are not able to post them. But soon we'll come back to the video mode and surgical demonstration mode again. Till then, enjoy or learn something from this very interesting case, which was actually a difficult case for us also to make a diagnosis. So let's discuss this case of voiding dysfunction. And to present the case, I have with me my fellow Dr. Dheera.
Hi, good morning. So this patient, Mrs. X, a 56-year-old coming from Karkala, she came to us with complaints of incomplete evacuation of bladder since 5 to 6 months and also vague lower abdominal pain since 2 months. On history of presenting illness, the incomplete evacuation of bladder since 5 to 6 months, every time she used to pass small amounts of urine, and she always felt she had the sensation that she needs to pass urine again. To the extent that 2 months back she had one episode of urinary retention where she had to go to the emergency and they had to catheterize her bladder, and at that point there was around 800 to 900 ml of urine which was drained out. Her abdominal pain is since 2 months.
So I'll take a break here, Dheera. This one message I want to make it very clear, okay? That whenever there is voiding dysfunction,
Right.
Like you told, maybe sometimes we are not taking proper history. Sometimes maybe patient is also not telling us and we are not asking, so actually we are finding out nothing. And suddenly one day patient presents with retention of urine. So any time if a patient presents with acute urinary retention, this is not a good thing. That means we have missed something.
Right. Yes.
In most of the situation in women, as far as possible, patient would have complained of some things before, some history, like you said,
Right.
incomplete voiding, poor urinary stream, double voiding, something she would have complained, which either patient has not told us or we have not been able to ask and leading as a leading question. So it would have got missed. And second thing, very important from this case, if any patient comes to you with acute urinary retention, mind it, just catheterizing is not the treatment.
Right. Yes.
Okay. So 2 months ago she presented. Actually, we should have diagnosed and treated her then and there.
Right. Yes.
Because this episode will keep on happening again and again. And what are the problems which can happen if the patient is having these kind of incomplete voiding and some retention or residual urine in the bladder? What all problems Dheera patient can have?
Since the urine gets collected, she can develop infections. So
Recurrent urinary tract infection. If not treated properly, and if these are too recurrent, what can it lead to?
Due to the backflow, it can lead to pyelonephritis.
Yes. So pyelonephritis, a patient can be really sick. So we cannot just ignore it. And if by chance these kind of acute, prolonged distension of the bladder happens, then it can cause
voiding dysfunction.
It can cause destruction of muscles, breakage
fibers
in between the muscle, detrusor muscle fibers, and it can lead to some kind of problems with detrusor muscle that it will never come back to normal. It can go into detrusor underactivity, DU.
Okay. One of the other causes of voiding
dysfunction. So the things are treatable now. They are in your hands now. If you don't treat, if there is a functional cause or there is an anatomical cause which can be easily treated, please don't leave it. Treat it then and there, because if you do not treat, it can damage the bladder, it can damage the kidney and the uterus. Right. Okay. So this patient was what was her age?
56 years
56 years old, postmenopausal women.
Yes.
Presented 2 months ago. Actually, I'll start my history from there only, with acute retention of urine. And on asking, she is giving history of other voiding dysfunctions.
Right. She says
lower abdominal pain might be a consequence of UTI now. Right. Isn't it?
Right. Yes.
Maybe.
Yes. So
Okay,
far, yes,
so-
ma'am. So far along in our history, it can be
like that.
because of that.
Okay.
Right.
Then what do you do?
Right. So her lower abdominal pain was non-radiating, dull aching, and it's on and off. In her past history, she's a known case of hypertension and diabetes, and she's on treatment. Her obstetric history, she's para 2 living 2, and with previous 2 cesarean sections.
Okay.
Right. And she attained her menopause around 6 years back.
So previous 2 cesarean sections, and she is a postmenopausal lady
Yes.
presented with acute retention of urine. Okay.
Right. Right. So moving ahead with this
Background in mind.
Yes, ma'am. So then we went. She actually came to us with a CCT report.
That we'll not discuss now.
Okay.
First, we'll do the examination. then
Right.
we'll talk.
On examination, her general condition was fair. She was moderately built and nourished. Her breast and thyroid were normal. Her BMI was 31 kg per meter square. On her
She
system
was on to the higher side.
Higher
only.
side, yes. She was obese.
You are very kind.
Yes. Yes.
Hmm.
And her systemic examination was normal. On per abdomen, we felt a mass, firm in consistency, around 18 to 20 week sized uterus. Right. And then on PV, we could feel the same mass.
So there was a mass which was around 18 to 20 week size,
Yes,
which
ma'am.
was felt abdominal, per abdomen.
Right.
And the lower border was.
The low border was not felt. The low border was not felt separately.
Hmm.
Yeah.
And can you describe this mass? How were the borders? How was the consistency?
It was firm in consistency. The borders were well defined,
Hmm.
and
Was it mobile mass?
it was a mobile mass. It was
Because can you tell me, Dheera, what
It
I'm
wasn't
thinking when you
completely-
said that
Right.
18 weeks mass in a patient with voiding dysfunction? What is, when you said that mass was there, why I'm asking you so many questions? Because what is my first thought? Can you guess?
the first would be fibroid uterus.
No. I'm thinking, is it full bladder?
Oh, is it a full bladder? Of course.
Okay.
Yes, ma'am.
Is it cystic inconsistency? Is it
Right.
painful
Is
to
it tender? Right.
to
Yes,
touch?
ma'am.
Okay, so all these. So first my mind is thinking, is it now we know the case, so we are deviated a little bit. But
Right.
when this patient comes to you, when you keep your hand in the abdomen and you find the mass and you tell to somebody, the first thing that should come to your mind is it a full bladder?
And with the history of retention of
urine,
urine, it will be more so
Yes.
you would keep that in mind.
Yes.
Yes.
Okay. But it is more or less ruled out because you said it is not cystic, it is firm in consistency, and it is not tender to touch, it is arising from pelvis. So let's see what it
Right.
is.
It's fairly immobile, ma'am. It wasn't
Okay.
completely mobile with, as in, it wasn't a ballotable mass. Fairly immobile.
Okay.
On PV, there was bilateral fornicial fullness, and we could, even on PV, the uterus was around 18 to 20 week size. It was non-tender.
First speculum.
Post speculum, yes, ma'am. The cervix was pulled up and it was anterior. Cervix was pulled up and pushed anteriorly.
Okay.
So probably because the cervix is pushed anteriorly, was there something posterior? That's why the cervix was deviated anteriorly.
So there is dysfunctional voiding or voiding dysfunction with the pelvic mass.
Right.
So which group of, we have discussed last time the causes
Right.
of voiding dysfunction. So which group you want to keep in Dheera?
So this would come under where the urethra fails to relax.
Yes.
So it's divided into either where the detrusor does not contract or the urethra fails to relax. So this would be under where the urethra fails to relax.
In that also
In the-
there are two groups.
Right, the anatomical and the functional. This would be an anatomical
Anatomical.
cause.
So perfect. There is an anatomical cause here of voiding dysfunction.
Right.
Last time we discussed the functional cause.
Yes.
So this case is different because today we are going to discuss an anatomical cause of
voiding
voiding.
dysfunction.
There is some mass. We don't
Yes.
know what that mass is till now, but it is a pelvic mass. It is posterior to the uterus.
Yes, ma'am.
Okay, so something maybe which is pulling the uterus behind,
Mhm.
and thus the cervix is jetting forward, and the urethra
ma'am.
is getting hinged between the pubic symphysis and the
and
firm
the-
cervix.
Right.
Okay.
Yes.
So this is the usual mechanism why retention of urine or voiding dysfunction happens because of pelvic pathology or
Right.
reproductive tract pathology.
Okay.
Usually something, it's not directly. So if I ask so many times in class, they say that the most common cause of urinary retention, most common type of fibroid which causes urinary retention is cervical fibroid. As an MCQ also it is a wrong answer,
Right.
because cervical fibroid to begin with are very rare.
Correct.
Okay. So most common cause of most common type of fibroid which leads to urinary retention is posterior wall fibroid, which pulls the uterus backwards.
Yes.
So the cervix starts jetting forward
Right.
and pinches the urethra in between the pubic symphysis.
Yes.
So okay, so this is the usual cause of retention. So here we are finding a mass. But do you think it, according to your history, according to age of the patient, do you think it is a fibroid?
Ma'am, if you go by the age of a patient, probably what I would say, this fibroid has been long standing. Because she's attained menopause 6 years back, and generally the notion is it does not, or it at least tends to grow much slower
It
after menopause.
regresses after
Regresses
menopause.
rather. Yes.
So I am also not thinking of fibroid. Though
Right.
fibroid is the most common case until now, whatever anatomical causes I have seen, either they are cystocele or if there is a mass, then it is fibroid.
Right.
But all were till now in reproductive age group
Yes.
women. 6 years postmenopausal, I cannot think that one fibroid, and she's not giving any history of menstrual complaints. She has
No,
never
none.
visited a doctor. So actually, I'm not thinking of, to tell you the truth, I'm not thinking of a fibroid.
fibroid,
Okay.
yes.
Because most important reason that she is postmenopausal. In postmenopausal women, we don't think of fibroid. Okay. Then what else it can be?
The other anatomical causes, ma'am, one, there can be a prolapse, but on speculum we saw that there was
ruled
no.
out. It is a mass.
It is a
We have to-
pelvic mass.
It is a pelvic mass. We have to find out what pelvic mass it is. Okay. So what will you do now?
So we went ahead with the ultrasound, because we also have the ultrasound machine at our disposal in the OPD. So when we did it, we saw the uterus was enlarged, and we had the suspicion of
Uterus was not enlarged. Uterus we could see,
right.
but there was a
separate mass, yes,
Yes.
which was coming, which we thought looked like it was coming outside of the uterus posteriorly, because it was a hypodense, a hypoechoic area, and posteriorly it was around 11 into 11 centimeters. So we still had the suspicion of a posterior wall fibroid in our mind.
So usually when we do ultrasound, it is not always. See, first thing that even if we are thinking of ovarian tumor, this age group in postmenopausal lady, it should be some kind of malignancy,
Right.
where ascites should be there. These are the common things. So we always say that think of common things first.
Right.
So there was no ascites. There was, uterus was seen separately, ovaries could not be visualized, but it can be a normal finding in a postmenopausal lady.
Yes, ma'am.
But there was a huge mass which was seen posterior to the uterus. Now we have to find out, it was more or less homogeneous mass. So we have two differential
differentials.
diagnoses. One thing, it was some kind of benign solid ovarian tumor.
Right.
Okay. And the other diagnosis which we thought it could be was a subserosal fibroid.
Right.
Okay. So subserosal fibroid maybe was asymptomatic in premenopausal time.
Right,
Okay.
correct, yes.
Because it was not lead to menorrhagia and other things.
It did not, no
okay?
menstrual
So it might, maybe patient was having some kind of voiding dysfunction that time, and it was not that significant patient for the patient to notice.
Yes.
Because if it was a fibroid which was intramural or submucous, patient will definitely complain of dysmenorrhea and
Right.
menorrhagia with this big fibroid. But the first differential diagnosis was, like two differential diagnoses we had. Either it was some kind of solid ovarian tumor, benign, which was without ascites, and the other thing, it was a subserosal fibroid.
Yes.
So what would you do, Dheera, next to confirm this diagnosis?
Because also we could not see the ovaries separately, and we still had the differential of an adnexal mass. So we did a CT.
You will do a higher imaging.
Higher imaging. Yes,
So
ma'am.
if you have to choose for
Yes.
this patient, which higher imaging modality you will do?
We go for an MRI pelvis,
Yes.
abdomen pelvis rather.
Yes. So what is the difference? How do you choose MRI? How do you choose CT scan for this patient?
Generally, ma'am, MRI, if we want to see more, MRI delineates soft tissues better than a
Yes.
CT scan. But if you want to see if there's any lymph node enlargement or that those are positive, to detect lymph node enlargement, a CT scan would be better. But for soft tissue enhancement, an MRI is better.
Yes. So as Dheera said correctly, I'll make it a little more simple for you all. When I want to have a bird's eye view, I
Right.
want to see the entire abdomen. If there is a metastatic deposit on the liver,
Right.
under the surface of diaphragm, in bubble, when I want to have a bird's eye view, I don't want clarity,
Mhm.
but I want to just pick up if there is nothing important anywhere else. In those kind of cases, we advise for CT. So if suppose it is a case of uh, carcinoma ovary or ovarian malignancy where deposits can be anywhere.
Right.
We just want to have an overall view of the abdomen. We must do a CT scan to find out, to have a bird's eye view.
Right.
Okay. But when we want to differentiate one tissue from other, okay, and see nearby soft tissue, as you
Right.
said,
Yes.
like in endometrial cancer, we want to see whether this endometrial cancer has gone into myometrium.
Myometrium.
Nearby,
Yes.
very good, beautiful
Right.
delineation with
Yes.
high resolution. Those are the cases when we do MRI.
MRI.
Okay. One more place where we want to see what is the content, whether it is a benign tumor. We know that only one tumor is there. I want
Right.
to see whether it is benign or malignant. Soft tissue differentiation.
Right.
Then we go for MRI. For this particular case, there was no ascites, though it was one possibility was ovarian also.
Right.
But we did not see any other sign of metastasis. She did not give any such history. So it is better. Our first thing was, what is this mass?
Right.
Not that how wide it has spread.
Right. Yes.
Okay. To differentiate that mass from 2-3 differential diagnosis, we must do MRI.
Right.
But the problem with this patient, she already came with
Came
a
to us with a CT report.
CT report.
Yes.
So spending her money again, we thought is not worth it because CT had already given us a diagnosis. And what was the diagnosis?
So the CT scan report showed there was a hypodense mass of around 12 into 12 centimeters with attenuation of fat. Most likely, they said it can be a right adnexal mass, like a right dermoid cyst.
So I read only this much. Then the CT said that it is a dermoid cyst.
Right.
And I was actually, to tell you the truth, I was a little excited. I thought till now I had not seen a dermoid cyst. Though theoretically it is a possibility, impacted dermoid can cause urinary retention by the same mechanism if it gets
Between the
impacted in
pubis
the
and physis.
if it gets impacted in the pouch of Douglas, again
And
it
then
can
it
retrograde
pushes.
the
Okay,
uterus.
right.
Okay, so that there is a theoretical possibility, but I had not seen a case. So I thought it would be a very interesting case. It is a dermoid cyst. CT scan says it so confidently, and with that thing in mind, we took her for surgery.
Right.
And what surgery you want to do for this 56? We could just have removed the ovary also, but when we discuss with the patient says that it is better. She wants
To remove the
remove the
uterus
uterus
as well.
also, and but it would have been an okay treatment if you just do a salpingo
Oophorectomy.
ovariotomy. These terms are a little confusing.
Right.
Oophorectomy we use when the ovary is normal.
Normal.
So salpingo ovariotomy we could have done and come out. But we discussed all the pros and cons with the patient, and somewhere in our head there was a diagnosis, because many a times it has happened that we have put a scope or we have opened it, and I'm sure it would have happened with all of you in gynecological practice, that we think that it is an ovarian mass and it comes out as a fibroid. And you think it is a subserosal fibroid, it turns out to be an ovarian. So this possibility is always in mind. So we counsel the patient that we'll see what it is.
Yes.
But still we went ahead thinking that it is a dermoid cyst. We'll put the scope, suck out the material, because what is fat is the sebum, which is in the dermoid.
Right.
Okay.
Yes.
So that's how we see it. And we thought we'll suck it out, remove the ovary, and then proceed further. But when we put the scope, what was the finding?
Yes, ma'am. So
First thing we saw was two shining,
ovaries, very normal ovaries.
very normal looking ovaries. And then when we put our scope, proceeded further with the scope, we started seeing more. Then we found that uterus was sitting on the top,
Right.
and there was a
posterior wall
fibroid.
fibroid.
Okay, just above the cervix, it was posterior wall fibroid, which was actually pushing the uterus anteriorly.
Right.
Okay. So we found the cause, big uterus it was, and then we proceeded with
Surgery.
hysterectomy. Okay. That fibroid, for 2 minutes it was a shock that we were thinking that it is going to be a dermoid, but it was not a dermoid.
Right.
Good for the patient, but it was okay. So now Dheera, tell me one thing, we had posted her for TLH.
Right.
If by chance this kind of thing happens, or maybe you know the diagnosis,
Right.
the patient is having a posterior wall fibroid
Mhm.
near the cervix.
Okay.
Important thing.
Right.
What are the precautions you are going to take? In any hysterectomy,
Yes.
but here we are talking about TLH.
Right. And most important is that if we know it's a fibroid, so that we avoid, first we delineate the margins of the fibroid, we visualize the ureter, whether we visualize the ureter and see the distance between the fibroid and the ureter. Also, in case we are enucleating the
Very
fibroid.
theoretical means there is, when the fibroid is pushing,
Yes, ma'am.
it is difficult to see the ureter
Yes,
for me.
yes,
Like I
yeah.
think because everything is so close. My
Right.
idea is I don't want to waste time in delineating and seeing the ureter. I want to be away. This is the simple thing I follow, and I teach also
Right.
that try to be as much away as possible. Last time also in one of the case discussions we discussed that we don't do ureter. I don't prefer to
Stenting.
do pre-operative stenting.
Yes, ma'am.
Follow principles and follow in every surgery.
Right.
So somehow you don't go near the ureters.
So you stay within the capsule.
Within the
Don't go
capsule.
outside
So
the
what
capsule.
I want to bring, actually we did this.
Right.
If I poke you a little bit more, you will
Okay.
tell me what did we do? Did we start hysterectomy? Did we start clamping the or coagulating the uterine pedicles?
No,
Before that,
we enucleated
Enucleate.
the myoma.
Okay.
Yes, ma'am.
So if it is in lower segment, please enucleate. Because if you have not enucleated, when you are going to do uterine arteries, you have to go more laterally and then you
Right.
will be close to ureters.
Ureters.
Okay?
Yes.
If it is upper segment fibroid, you can leave it. But if it is lower segment fibroid, always practice this, that enucleate the fibroid first or do myomectomy first. Keep the myoma there only
Right.
and then go to the uterine arteries.
Right.
Then you will be
It's much
close to the
safer, yes.
cervix, and it is much safer. You will be away from the ureters.
Yes.
Okay?
Yes.
This is one very important. Then we did myomectomy first. We let the little pedicle attached to that segment,
Right. So that yes,
while
ma'am.
removing it is easy for us because TLH we are going to remove the specimen from the vagina. Otherwise, like a ball, it will start troubling us.
Yes.
So we left a little pedicle there, but from sides we enucleated and did a myomectomy.
Right.
After that, we proceeded with the hysterectomy.
Hysterectomy. Yes, ma'am.
Then what did we do? Then when we were in removing it from the vagina,
Right.
then what happened? Then did you notice, was it a different mass as compared to?
It was a very soft mass, and we weren't, because it was soft, we weren't able to get hold of it very well while mosulating it through the vagina. And then we of course had the suspicion whether there was it a leiomyosarcoma.
Yes.
Yes.
So it is a very important point that it can be. The report is still awaited because the pathologist said that 2 days more they want to do, a histochemistry because they are also not sure what it is.
Right.
It was a different the consistency was not like fibroid.
Right.
That's why I think all confusion happened. We went back and spoke to the radiologist that why did you report it as dermoid? Then he said that they have not seen so much fatty tissue
Right.
inside fibroid. So they thought it was sebum which is in the dermoid. That's why they also got confused. MRI. So definitely Dheera, MRI would have been a better choice of
Right.
investigations for her. But once patient has gone and done her CT scan before, we don't want to do again and again repeated investigations.
The financial burden also.
Financial burden also is there, at least in India, because it is not covered in the insurance or
Right.
not paid by the government. So then one question I have for you, when you were trying to morcellate it,
Right.
it was not coming properly.
Yes,
Okay, it
ma'am.
was very soft, you said, and there was some fluid kind of content which was coming out.
Right.
Usually the consistency of fibroid, it should be firm.
Firm.
And usually you are able to do nice myomectomies if there
Right,
are
yes, you're
small
able to
fibroids,
morcellate it
morcellated, very good. So what were the things which were in your mind, that what are the possibilities you thought of?
One was, yes, the thought of a leiomyosarcoma did come to our mind, but there was also a comfort that it can be a degenerated fibroid.
So it can be a degenerated fibroid, and that's what we thought. And then in these kind of cases, it is very important. Then tell the pathologist that what you have been thinking. What was your diagnostic dilemma? It is very important to tell them this. So we have spoken to them. and now I think it is around 10 days,
10 days.
and they have
yes.
not been able to. They are still thinking they want to do immunohistochemistry,
Histochemistry.
and they want to report it. But so there are two differential diagnoses in our mind. Either it is not leiomyosarcoma, but it is lipoleiomyosarcoma.
Yes, lipoleiomyoma. Lipoleiomyoma. Yes.
Or it is leiomyosarcoma. And these are the two things they are thinking, because it is rare to have. There are some case reports. Later I read also that fibroid has many kind of degeneration, but fatty degeneration of fibroids, it's a little rare entity.
Okay.
So there are many single reported cases in literature. Very recently, these are not old cases. So cystic degeneration and calcified hyaline degeneration we get very commonly, and that's what created confusion here, starting from the diagnosis till now. It is still creating confusion that fibroid usually will not have so much fatty content in it. Okay.
We also done the LDH, ma'am. The LDH was normal.
That is also one relief, that LDH. Usually LDH, why did you do?
Ma'am, it is again in cases where if it's a leiomyosarcoma, the LDH would be raised generally.
So LDH was normal here, so we are thinking that we are just hoping that it is not sarcoma. But even if it is sarcoma, the treatment is like, that's what is the treatment for.
Also.
Yes. And the patient has gone home.
Yes, she was well post-op, and we discharged her.
So she had a big fibroid, and she had previous 2 cesarean also, but TLH could be done for her.
Yes.
Now patient has gone home, and she is supposed to come in a few days for the post-operative checkup. More important than that, we are just waiting for the histopathology report, so that we can just prognosticate and give her the follow-up plan.
Yes.
So Dheera, now you tell me, after having managed this case nicely, what are the 4 or 5 lessons, even after discussion, what do you want to tell to the viewers? What do you have learned?
Yes. I would say first, in the history, one learning point is, if any woman comes to you with any menstrual complaints or with a previous report saying that they have a myoma in it, even if they do not complain of any urinary complaints, we should ask as a leading questions whether she's able to empty her bladder completely, because we don't want her to go into an acute episode of urinary retention.
Very good. This is very important, and since I have started practicing this point, there are many women who are having actually this problem, especially if the ultrasound shows a posterior wall fibroid. Maybe with some tranexamic acid and meftelspaz, you can manage her dysmenorrhea.
Right.
But if she is having urinary complaint, that will not go away with that.
Right.
That requires some kind of medical or surgical treatment, which helps to either decrease the size of the fibroid or removes that mass.
Right.
Okay. Right. Otherwise, so it is very important, because it is very difficult for the patient to correlate that her menstrual complaint and their urinary complaint have the same reason. Okay.
Right.
And usually these women, even if they tell their urinary complaints to somebody, then they are again treated as recurrent UTI. There are many a times, one of the, I will not say most common, but very common cause of recurrent urinary infection in reproductive age women, which I am seeing, is a fibroid.
Right.
So they should not land up with acute urinary retention. That's what we have to be vigilant. That's what Dheera wants to say.
Right.
Okay. Yes. What is the second point you want to tell?
That was on history. On examination, an important point to note is about the pelvic mass, the examination of the mass, and to rule out between a fibroid and an adnexal mass, like whether with the borders, the mobility. If the cervix is pushed anteriorly, you would know that the mass is probably posteriorly. That's why it's pushed anteriorly. If on examination you can differentiate between an adnexal pathology and a uterine mass, that also should be examined well.
Yes. This was a little atypical case, because patient was postmenopausal, but many times this might be a diagnostic dilemma in a reproductive age group women, where a good history and good examination will help you to differentiate whether it is an ovarian tumor or it is a fibroid. Subserosal fibroid. Yes.
Coming to an investigation, if you want to have delineation between soft tissues, go ahead, if you have the choice of making a choice between a CT and MRI, go ahead with an MRI first.
Very good. So if you have confusion, what kind of, you are seeing a mass, but what kind of mass it is? Is it cystic, solid, benign, malignant, arising from ovary or uterus? If that kind of dilemma you are having, please go ahead and do an MRI.
Probably surgically, an important take-home point would be if you're dealing with a large myoma, to avoid any damage to the ureters, always stay within the capsule. Then you would avoid any adverse event.
I will say within the capsule means remove the fibroid.
Remove the fibroid first. Yes.
Do the myomectomy first, so the uterine vessels, because if the fibroid is arising from the uterus, it will be pushing the uterine artery laterally,
Right.
making it very close to the ureter. So if you start coagulating, especially in laparoscopic hysterectomies, if you start coagulating, you will burn or you will give some kind
Thermal
of
injury,
thermal
yes,
injury to the
the
ureter
ureter.
also. So always, it might take 10 minutes more, but always try to enucleate that and have the uterine arteries just parallel, just very close to the internal os or the cervix, and then coagulate them there,
Right.
rather than going laterally.
Yes. Post-surgery, always follow up the report and speak to your pathologist so that
Yes.
even they know what you are thinking. Yes, and we don't miss out anything.
And one very important, always this, I feel this is a big learning point, that always talk to the radiologist also who has
Right.
reported, because it is continuous. Medicine is not same all the time. And we say that it is very difficult to see two similar cases in one lifetime,
Right.
exactly similar cases. So you have to give the feedback. The more you strengthen your team with the feedbacks, and whether it is positive feedback or negative feedback, every negative feedback will have a learning for you and for them
Right.
also. So always you should be in communication so that you can be better as a doctor, as a clinician, and you can give a better management to all your patients.
Right.
Okay. So Dheera has promised today to all of you that she'll be posting some surgical videos.
Soon.
I hope it comes soon.
Yes.
So they are operating a lot, but only thing is that video recording, sometimes some issues, sometimes other issues happening, so not able to record. But I hope you are operating enough.
Yes, ma'am.
Okay.
Yes, we'll
Okay.
learn.
So soon we'll post some urogynecological video for you to see. Thank you so much.
Thank you.
Keep watching. Thank you.